again, thank you for taking the time. And if you have any questions along the way, I'd prefer to do it more in a dialogue fashion. So please ask as we go through. If you want to raise your hand, Allison will, Allison, do you have instructions about how you want to handle that?
Yeah, so if you want to raise your hand, you can unmute, or if you want to put something in chat, if you don't feel comfortable, talking, I can ask that throughout as well.
All right, thank you. Well, I'm Ginny Pribanic. I am Tepper, and I love CMU. I love all things CMU. And I've been a long-time entrepreneur, very long, and I love it. I really enjoy being an entrepreneur, and I just really want to emphasize what I think are the most important elements of entrepreneuring, and it's you have to have a passion. You have to get up in the morning when it's going well, and when it's not, you have to have integrity, because once you would develop a reputation of not being a reliable, honorable human being, it'll get into the field very quickly. You have to have courage to take on challenges and resilience, because I can guarantee you things will go wrong. Well, just 1 second to tell you one thing about me is I have been clinically diagnosed as intense. By that, I mean that I just have an intense personality, the way I deal with things. And I do think that helps me as an entrepreneur. It helps me in many ways. I'm also Pittsburgh made and proud. My undergraduate degrees were with the University of Pittsburgh, and I graduated from Tepper. The technologies I've used and the companies I've built have often been from CMU researchers, and that's true with what we're doing right now with MedRespond. And MedRespond uses conversational AI to simulate a conversation with patients. So patients go to the website, they're going to have open heart surgery. I'll use that as an example because it's the one we have the most data about. And the coach, Darius, greets them and said, "How are you today? How are you feeling about your surgery?" She asks them questions, they respond. Based upon the way we respond, we change the, we respond appropriately to their fears. If they're afraid, the next, our coach, and it's all a video coach. We don't have any people in the mix. It's all an AI-driven conversation. And if the person says they're frightened, she'll say, "Oh, that's really normal. A lot of people are. But the more you know about what's going to happen, the better off you'll be." If they're doing great, she'll say, "Oh, great, that's good. Glad to see you're doing fine." And what we found is people like that way of interacting with that video coach. I've heard people say, "She makes me feel I trust her. Her calming voice calms me down. She makes me feel like she's really interested in what I'm saying." And we've studied the outcomes of the data for the usage of the program in several hospital systems. And I guess the big takeaway is our client has studied what the impact on post-discharge costs. So for the 30, 60, 90 day post-discharge, what happened to the cost for the people who used the program versus the people who did not. And what we found is in the first 30 days, the costs were 50%. If you take that full time and extend it to the 180 days, across that whole time frame, we save 30% of costs. And what's that about? Well, when we do the education, our education in the system that we deliver to patients is about what can go wrong and how to prevent it. So we focus on falls, we focus on infection, we focus on following your care plan and knowing what you shouldn't be doing, when your restrictions, and when to contact the doctor for things like that. And it's making a difference. On average, an average patient uses the program to prepare for their surgery for 90 minutes. And that's consistent. We've seen that utilization for several years now across different implementations. And one of our clients did a survey of their patients asking them, did this program improve, we improved patient satisfaction scores, but another hospital system asked if the surgery preparation improved their overall care experience, and 100% said it did. 93% said it strongly did. So it's really making a difference. And we are now expanding our program to support other surgeries and to support other hospital systems. And in doing that, we've been doing that, focusing strictly on patient engagement now for about the last 5 years. And we've run into all the challenges that I'm going to describe for you today. And so what's the big deal about working in healthcare? Well, one is it's really, really big, and it's getting bigger. In terms of percentage of GDP, it's about 18%. In the last 2 years, it's growing at a faster rate than it has before that. So it's actually crossed 18%. So that's $3.5 trillion is a nice little opportunity to get into this market segment. And it's a really easy to find healthcare. It's not like you have to do a lot of research to find who's spending the money and where the care is. If you look at there's two key sectors that represent over half of all spending: hospitals and physicians and clinical services. So you can find the money, you can follow the money, you know where it is. Easy to find them. You can just look in your neighborhood. You can find there's over 6,000 hospitals, nearly 1 million staffed beds. There's 36 million admissions, and there's a lot of money in being spent just by the hospital sector. And it's easy to get data on this sector. There's all kinds of research resources that will tell you everything from the best hospitals to the individual statistics for hospitals, how many surgeries are performed at each system, what their average ratings are, their costs. There's really a wealth of data about this sector. So if you're looking to do that analysis, you'll be well supported in it. So what's the problem? Well, let me start with probably the newest one, and it's one we're all quite aware of. It's COVID-19. And it's greatly impacted, first, the financials of the system. This is early data from the initial bang that it took, and it was such a surprise. I happened to come across some emails from last March with some discussions with some surgeons saying, oh, this will be in March 2020. This will be over in a few months. Don't worry about it. Well, this will all be gone, because no one anticipated what was going on. And you can see with these revenue spending, the revenues per hospital incredibly dinged. The operating margin went down to below 5%. But fortunately, the relief funding helped subsidize many of the hospital systems, so that with relief funds, they softened the blow for many of the providers. What's this caused? The really big problem for COVID within the provider system is it's become a staffing crisis. The surge nurses are burnt out, and it's making a mess of staffing. They're leaving the workforce. They're restricting their hours because of their workloads, fear of infection, and anxiety. There's data, and it's actually the last bullet here describes what people are contending with as a war zone. People are experiencing symptoms similar to PTSD. And it's because they're facing death every day, and needless death and stress. On a personal level, this is Dr. Kulig, who is the director of cardiac surgery at Excella Health and a friend. And he states it so well. because we have a staffing shortage, there's fewer beds, and they're being occupied by COVID patients. So we're delaying regular surgeries for dangerous conditions and cancers. And people are getting more and more burned out, and they're begging for help. The Cleveland newspaper ran a full-page ad from the hospital system, and it had one word on it: help. So it's a shame and it's sad, and it's really, if you know many people in healthcare, buy them lunch. It's really a rough time out there. But from a business perspective, what does this mean? It means you can't get people's attention today. It means people are completely distracted. I've been in the process of negotiating a contract for about 10 months, and we were very close to the end on signing the paper. And I was following up, and I was having a little bit of difficulty reaching people. And finally, they got back to me and said, "Look, we want to do this. We really want to do this. But we cannot. We're completely overwhelmed. We're getting 1,000 emails a day. We have such a staff shortage that my administrative staff is actually helping the nursing, and we're doing everything we can to keep afloat and take care of all the patients we have." So COVID has made it really very difficult to do business if you're selling to providers or selling into the healthcare industry. Another thing is that a lot of the hospital expenses are being redirected from everything else to only support initiatives that are COVID-based. What I've also seen is many programs that were scheduled to start in 20 have been pushed back. Hopefully now we'll be able to get back on track to the second half of 2022. But again, I can't emphasize enough, COVID has made it really very, very difficult to do business in healthcare, and startups are taking it hard, and it's pushing people out of business. It's really a difficult environment. So what else is healthcare? Once COVID goes away, we'll still have the other issues behind healthcare. Let me stop right now and just ask if anybody has any questions or comments. All right, great. Thank you. The challenges we have in healthcare is it's become a political football. Is it a privilege or is it a right? Are we going to increase spending? Are we going to eliminate the Affordable Care Act? It's all become something that is debated and fought on the political scene. And that is a heck of a thing to do to a business person, because we need stability and predictability, and the healthcare profession does not have that. And healthcare is very difficult because it's responsible for lives. So to ask people who are responsible for caring people and keeping them alive to make changes is going to be scrutinized. It's complex, it's regulated, there's complex payment methods, and the healthcare system is under incredible pressure even before COVID, but COVID has just heightened that. So the fact that they're responsible for lives, they have an obligation. They can improve upon current standards of care, but above all, cause no harm. And so their goal is to increase efficiency. Innovation cannot jeopardize lives. So you as an innovator, as an entrepreneur, you have to demonstrate to any provider or any healthcare system that you're attempting to work with that you will not impact care. And the burden's on you to demonstrate that. So that's a challenge. There's also, one of the challenges you're going to have is you're going to be asked to prove the impact of your innovation, which can really be difficult because of the lack of easily accessible data. There's plenty of data, but it's not what you want and it's not how you want it. And part of the challenge is interoperability of the data is really lacking. So many hospital systems have one electronic health record for inpatients and a completely different electronic health record system for outpatient. That's not uncommon at all. And they can't share the data between the two systems. So when the patient gets diagnosed with early stage cardiac disease by their primary care physician, you don't have a continuum of the patient's history and costs and events through their whole life cycle of care. The electronic health records are rigid, and it's because it's very, very complex. They are so, just keep adding on those complexities to it. These are enormous systems that take a lot to keep it running, to keep it efficient, to educate people how to use them. It's just really, it's really a challenge to support an electronic health record system. Within that system, people often don't follow the directions when they fill out the information. So sometimes critical data is not coded. Like there's a code for the prescription status, but if someone's in a hurry, they just throw it in a comment field. So you're not going to get the data that you really need. This is a one we really see a lot of challenges, is that the clinical data is in the electronic health record of the hospital systems, of the primary care providers. But the payments and the revenue that flows are in the claims data of the healthcare provider, which are two different systems. So you've torn apart the services and its revenue, and it can be very, very difficult to combine those, match those together, and really do the kind of evaluation that you come to expect in any other business. It really is a challenge. People say, show me the outcomes of your innovation. Just begin to think about what the complications would be when you have all the data of what happened to that patient, and then you have comorbidities, and then you have it spread across different systems, and then you have costs in a completely different company, the insurer, who is not very eager to give up their data on costs, because that's an intellectual property and an asset for them. It's very important. So the bottom line to that is proving efficacy of your technology and the impact you're having is a challenge. But let me say that doesn't seem to get in the way of many people who sell into this industry, making claims all over websites, saves 50% of costs, reduces readmissions by 400%. It's just, the claims out there are amazing. And, if you have an experience with the system, you realize you can see quickly which ones are real and which ones are just wishful thinking. So be careful of that and be cautious with that. Hospital systems are complex. Most hospital systems, the enterprise has multiple hospital systems across multiple locations. They have different, what they often call institutes. So they're areas of clinical care. One institute might be HVI, another might be orthopedics. And so several hospitals, they have 16 hospitals in their system. Several hospitals deliver those services, but they're administered through a central institute management level. So there's a director and a head of all cardiac surgery across the whole system. But within each hospital, you have a director or an EVP who manages it within that system. And so you have a lot of matrix organizations and matrix decision making. And you have individual variances within enterprises, within hospitals. So getting to understand and sell into that can be a challenge. There's also hundreds of primary care practices. There's many outpatient centers. There's also the labs and clinics. So it's a complex structure of interwoven organizations that make up the healthcare system. You have system level leadership, you have hospital level leadership. That goes back to the matrix I was just describing. And then you have service level management leadership. So it really can be complicated. And then you layer in all of that, the governing committees, the federal regulations, the clinical guidelines. It really is, it's a complex area. It's a complex system. It's also, as I just started to mention, heavily regulated with the FDA, JCO. There's legal requirements, compliance. There's internal review boards that review every document and every study that's done and every process to assure that it's respecting the patient and it is safe and not crossing lines. You have confidentiality and Hipaa and data security and cybersecurity. Hospitals are being targeted by ransomware. Just last week, there was a ransom attack that in a Florida hospital system that demanded $1 million to give them access to their own data again. And the head of IT within that system shut down all of IT because the minute he saw it showing up at one location, he shut down the whole system. And imagine being the IT manager in that position, deciding if you're going to shut down the electronic health records across your entire system as a defense strategy. But that's exactly what he did, and he's being credited with saving the system a lot of money, injury, harm, and ransom. So when you're going into the system and mentioning all that healthcare, it's regulated, you're going to come into having to meet the requirements of all these systems and review periods. And within that, these administrative, it's not a checking the box kind of regulatory system because the penalties can be really severe. Here's Hipaa violation examples. It's $100,000 to $50,000 for a first-tier incident violation in Hipaa, up to $1.5 million. And then it's $1,000 to $50,000 per incident, up to $1.5 million. And look at the kinds of numbers you're talking about for inadvertently giving access to a patient's data. So if your system and your technology requires you to handle the patient data in various ways, this is what you're opening up the hospital up to, and yourself. So you can understand why there's a lot of scrutiny over any new item that comes into a hospital system. The other item that can happen is malpractice is very real. And I just pulled a few out of here where the malpractice was related to a new technique. And there's the New York hospital with $62 million in a settlement because they strayed from the required standard of care. And the second was an example, they used an inappropriate surgical technique. Was this an innovation? And they had to pay $60 million. The last one is they were using an unproven technique to administer several surgeries. And the medical malpractice was $30 million. So if you introduce a new procedure, a new technology, a new system and information into the hospital system, and it reduces the care or puts the patient at risk, this again is the kind of scrutiny the system comes under. There's a complex buying process. So the decisions are often siloed. They're made by, like if they're in a 16 hospital system, it may be the surgeons who make some decisions. It may be administration that makes some decisions. It could be at the hospital level. It could be at the enterprise level. And so the decisions are siloed. And there's many decision makers and influencers at all levels. And this is really something that I found particularly challenging is there's many gatekeepers. You have the supply chain group who negotiates the contracts. You have the legal department that has to approve every transaction, every sizable transaction. And then you have IT and cybersecurity who really require a high level of scrutiny into your system and to assure you're not going to put their data at risk. And then sometimes the formulary is described by the insurance and the payers within this system, and their formularies can limit what people can do. So you may come up with a new innovative procedure, but if the payer doesn't agree to pay for it, it's not going to be adopted. So those are all, it can get complicated. And what this points to is a very long sales cycle. And I'm talking to sell into a new hospital system on an enterprise level. It can take 18 to 24 months. And I've seen this, and I've interviewed other CEOs, same experience across many, many, many companies. This is not unusual. We're negotiating 2 contracts right now, and we're in the supply chain area. And we had all the terms identified, and we were in perfect agreement. And then to formalize that into a contract within the hospital system has taken 10 months to a year. So you have all the sales of, to convince the users and the providers, and then you can end up slapping on 10 months to get through the legal and supply chain gates. And I was working with a supply chain manager in one of the larger systems, and I was amazed that it was taking 12 months to work through the details of a contract until I understood our contract was for a new innovation. So they had to define how it was going to be used, the specifics of the innovation, new pricing, new budgets. So it was really from that sense for the system, it was an innovative contract formula. It wasn't buying Q-tips or needles, something that can be easily defined. So there was one agent within this very large organization supply chain who was responsible for negotiating every contract, every complex contract like that. And the day we were finalizing things, she told me that she is tracking 56 different complex contracts through her process and through her system right now. And I can't even imagine keeping track of 56 contracts that looked like ours. And ours, after it was scaled back, was a 32-page contract. So it's important. It's important to recognize. So what does this mean to the entrepreneur? It means when you're developing funding, this sales cycle is going to delay your realization of revenues. And so you have to find an ability to fund your company and fund its operations during an 18 to 24 month sales cycle. Now, we're looking for creative ways to partner with people who are already in the hospital systems so that we can shorten this time so it becomes not a new vendor and a new technology and a new contract, but an extension of an existing contract. And we're hoping, and I think innovations like that are really important to keep in mind as you're tackling the healthcare buying process. And I want to pause again to see if anybody has any questions. I think the challenge of the Zoom is you really feel like you're sitting here talking to yourself. And then you may, because everybody may have left. The other thing is there's an evolving payment model within healthcare. You know, it started out as a fee for service. You got an injection, that was $20. You got a surgery, that was $30,000. You delivered a baby, that was $5,000. But now what's happening is those payment structures are evolving into value-based and bundled payments. So instead of the hospital submitting a charge for the patient taking an aspirin and taking an operating room and taking a hospital bed, there's an agreed-to price that they're going to get for a hip replacement, and that might be $18,000. There's an agreed-to price to do a liver transplant, and it's from beginning to end, all in, it's around $700,000. So, and it can be a hybrid of that, because some of the liver transplant costs are not included in the bundle and some are. And who benefits from the innovation can challenge the adoption of the innovation. So if you have a system that's fee for service and you say, I'm going to eliminate a service, you've eliminated a fee. If a hospital gets paid every day the patient's in the hospital and your innovation reduces the length of stay, you've just eliminated a billing for one hospital visit. But if they're under a bundled payment structure, you've made that procedure more efficient. So again, it's more complexities within the system. So really understand those complexities as you design your product and as you design your sales model, because it's really going to do your homework up front to understand how you can simplify getting through that process. And this gets back to, you know, I already said how stressed the health system is with COVID. It was stressed before COVID. People are doing more, the resources are less, everybody was overloaded. The hospitals have razor thin margins, 1% to 3%. And if you say to them, oh wait, here's a great innovation, to many people that's a burden. That means I have more work to do. I have to set up meetings with you. I'm going to take away my top resources and discuss care plans. And so innovation is really can be seen as another strain on an already strained system. Now, I know that the result of implementing the innovation is intended to save time, to increase efficiency, and improve outcomes. But the actual process of evaluating innovation and implementing it is going to be a resource burden on your customer. So you have to make it easy to buy and easy to use, because you want to make that burden for them as small as possible. And you have a lot of personalities and individual interests that can impede the adoption of your innovation, because people are invested in the status quo. That's what they are. They're comfortable. They know it. They know everybody who currently provides that product. They know how to use that product. Sometimes there's a physician culture where the physician doesn't want to automate a specific process because they want the individual control and the freedom and flexibility. And you can have conflicting motivations within a system when you look at the provider motivations versus the CFO. So that frontline physician wants to do everything to keep that patient healthy, and the CFO wants to reduce costs. There's going to be a conflict between those two groups. And there's teams. You have a team. Sometimes I get on a call with a hospital system or a payer, and there's 23 people on the call. Very large groups and teams, and working through that can be a challenge. Sometimes there's a not invented here attitude. Some hospital systems are notorious for not looking at anything that they didn't do, or once they view an innovation, trying to replicate it themselves. So it's just something you need to look out for. And they're also, nobody does it better. All of these things can lengthen and or stop your sales process. There's also a complex system of payments. So you have, everything's paid by third parties. You have government or private insurers or combinations. And those insurers who are completely separate from the payer approve the innovations that can be used and the pricing. And so you've really severed the control of the financing and the flow value control from the operational responsibility. And that's a challenge. And the insurers may not agree or see your innovation as a benefit. And there's an interesting thing that happens with the levels. I was looking at this billing and insurance VIR costs. For Medicare, it's 2 to 5%. For private insurance, it's 17%. So this is part of an entire article written on looking at excess costs and administration and how to reduce it as a major source of inefficiencies in the system. But this is something you need to keep in mind. Who's going to pay for it? How is it going to be paid for? Is there a billing code that they can use to submit to the insurance provider? Or do you need to get a new billing code set up for that? So it's complicated again. This just lays out the different options. Now you have Medicaid, ACA, the exchange, and just all the different, reiterating the fact this is a complex payer network. And there's another area of healthcare challenge that is really gaining an incredible focus right now, and it is on the social determinants of health. So these are things that happen that are a part of a patient's life that have nothing to do with the healthcare system, but will have an enormous impact on their health. And the factors that are studied are their ability to pay bills, their neighborhood environment. Do they have a safe park? Do they have access to foods? Or are they in a food desert where they can't get fresh food? The level of education, both in health-related education and general literacy, to be able to help people work through the instructions they're going to get. Food. A lot of people don't believe that there's hunger in America. Well, there certainly is. And when you can't eat, healthcare can become a secondary priority by far. And the community, and then you finally have the healthcare system. But you look at all these factors that are impacting what happens to that individual that are completely separate from the healthcare system, but they impact the way the healthcare system needs to reach patients, needs to provide and support them, and the outcomes they can expect and how they can maximize those. So that's another area, but it's a great area of opportunity for innovation to be able to customize the delivery to address these things. And I can't go far without mentioning 412 Rescue as our incredible resource locally to fight hunger. So kudos to our incredible group here. It's just an amazing organization that I can't be prouder to know. But so what's the takeaway for today? If you're considering starting an innovation, starting a company, and your target is healthcare, be sure you're targeting innovations that improve an existing process, rather than try to redefine an entire workflow and care plan, because an improvement is hard enough. If you try to redefine it and you don't have an area currently respond, it just would be a nightmare. Focus on ease of use, ease of adoption, and ease of buying. And when you're designing your program, make sure you understand the workflows for all the stakeholders who are going to use your system. You need to understand what's the impact on the nurse, the physician assistant, the anesthesiologist, the surgeon. How does this impact everybody? How does this impact administration, coding, billing? All of those, because along the way, any of those could be a roadblock to adoption. The other thing is the big understanding the path to scalability. There's a real pitfall that can happen in healthcare, and it's happened to many startups, where they start working with and get involved with a major healthcare system and customize their product to the delivery and customize it too much, so that their product is no longer something that can be easily adopted by other systems. So always keep your eye on the ball for scalability and how you deliver the product across the whole market, not just a specific client. Prepare for the long sales cycle that I described. You need to have funds to be able to survive that and support a very large marketing and sales effort that's not going to show an ROI for 18 to 24 months. The hard model to build and to sell. And when you're going after targets, you have to have a very deep pipe of targets and prepare for low success rates. Because as I mentioned, there's lots of things that can, you start out great and you run into a personality conflict or someone who has a major objection to the kind of approach you're taking, and you can just get killed anywhere along the list. But never give up, never give up, never give up, because it's hard to beat a person who never gives up. And I never quote sports, but that's from Babe Ruth. So I figure I'll leave you with that. And again, I'll open it up for some questions or comments, and I'll also ask Allison to provide my contact information to you. So if you want to reach out to me individually with any questions or I'd be very eager and willing to help. I've met with people from after prior presentations at short centers, so I really enjoy doing that, and I enjoy interacting with you. So again, I'll leave it open and ask Allison to tell me if there's any questions or
yes, I don't have any questions.
Any comments
in chat, but does anybody have a question when unmute?
Yes, I have a question.
Okay.
Yes, so Ginny, thank you. Thanks a lot for such a great presentation and for letting us know the practical aspects of commercializing the medical technologies. So I'm also trying to launch a medical device. So what I got from your presentation, is it true that the digital products are like more difficult than the physical hardware to sell to the systems or to convince them to buy them?
No, because you don't have to go through the FDA well, it depends. Sometimes software products do have to go through an FDA process. It depends on how it goes. I don't think I can say generally one is versus the other, because I really think you have to look at the specifics of the software product versus the device to identify which one would be easier to harder. My reaction would be they're both hard. But also, and again, I don't have a good basis for saying this, but I almost think that if you're selling a device, you are probably going to partner with an existing device manufacturer or the existing device distributor to get in the system versus trying to sell that device into healthcare systems directly. Though I know people who are doing it. It's tough. It's hard.
Got it.
But good luck to you.
Thank you.
Okay, do we have any other questions? Okay, well, if we don't have any other questions, I want to thank Ginny so much for coming and giving this talk today, and I'll share out her contact information to you all as well after the talk.
Thank you all, and have a great day, and I hope I see you next year in person. It would be good to do that.